All righty, we'll go ahead and kick it off. It is truly with a lot of excitement that we welcome you to the Power Over Scoliosis webinar. You can see the moderators for the event will be myself. I practice in Philadelphia, and Dr. Bachmann, who's a pediatric spine surgeon in Charlottesville, Virginia. We're joined by a great internationally known faculty. I mean, these are truly the world's leaders. You have an opportunity to ask them any questions that you'd like concerning our topic. And I'm very excited to have three of my very close friends and world leaders in care of children with scoliosis, Dr. Castelein, Dr. Mehta, and Dr. Dahl. But even more importantly and more impressively, we have two patient ambassadors who are going to be sharing their stories with you. And I'm super excited to hear both of their stories. I can tell you these stories end up being the highlights of our webinars. And we are very lucky and thankful to have Aisha and Ava join us today. But just some housekeeping, please submit all your questions through our Zoom Q&A. What we'll do is after the presenters are done with their talks, we will go ahead and use your questions as the first line of questions for our speakers, and then we'll run through as many questions as we can get to during our hour. We are very excited that you have joined us, and our agenda today is going to start off with a talk on Scoliosis 101, followed by a talk on nighttime bracing, and we have two fantastic patient stories today. Ava will relate to us her journey with bracing. And then after that, we'll go into vertebral body tethering surgery, followed by a talk on returning to sports following spine fusion and non-fusion. And then our second story will be with Aisha, who will talk to us about her story after a posterior spinal fusion. Before we get started, just a couple of words on our foundation. The Setting Scoliosis Straight Foundation is a nonprofit 501c foundation that was established in 2018. Our mission is to better discoveries and advanced techniques in the treatment of scoliosis in children and adolescents worldwide, which is in line with our vision where we see a future where children with scoliosis have the ability to live healthy, happy, and productive lives. So with that, I'm going to pass it on to my co-moderator, Dr. Keith Bachmann. Take it away, Keith.
Thank you, Dr. Samdani. I'm just getting my slides up here. Excellent. Hopefully we're seeing that nicely. Try to give you a little bit of a rundown. Thank you all so much for joining us. I'm very excited to be here. As Dr. Samdani said, I practice in Charlottesville at the University of Virginia. I'm an associate professor there. These slides were originally created by Dr. Peter Newton. I modified them just a little bit, but we're going to talk about what is scoliosis and how often does it happen. So the spine itself, this is the view that we would be, used to seeing, a straight spine. It connects our head, our rib cage attaches to it, and then our pelvis down here at the bottom. And you can see some sort of cutouts or breakouts of individual vertebrae as we look there. But in scoliosis, that spine, that curvature of the spine that is present when you look from the side, it begins to rotate. And so then on these x-rays, you can see this three-dimensional model building up where the three-dimensional changes that happen in scoliosis, the rotation makes us be able to see some of that angulation or curvature that's typically present only when you look from the side. We can then see it on x-rays from the front, and it creates changes on x-rays when you look from the side. There are a wide variety of causes and a wide variety of shapes that scoliosis can come with. And so we will mostly be talking about idiopathic scoliosis today. And then the scoliosis can result in shape changes of your body. And so attempting to address those shape changes by addressing the spine is one of the things that we look for. So shoulder height differences, trunk differences, scapula differences, shifting of the trunk, creases on the side of the body, things that happen as a result of that shape change. And then the most obvious or the most common with scoliosis is this rotational difference leads to prominence of the rib cage on one side, because the ribs are attached to the vertebral bodies. And so that creates change there. The spine is the structure for the ribs that then contains the lungs that help us breathe, the heart to pump our blood. If you have mild scoliosis, we don't anticipate any impact on these organ functions. More severe scoliosis can lead to problems, impact of breathing. And so then talking with surgeons or folks who take care of this to try to help steer and navigate and minimize any risk there. About 3% of healthy teens, so this big square of 100 here, you see 3 have changed color, about 3% have scoliosis. Fortunately, very mild curves are the most common. When we look at a more severe curve range, only about 1 in 5,000 people, and unfortunately more common in girls than boys, and we really haven't unlocked why that's the case. Scoliosis with other conditions associated with cerebral palsy or neurofibromatosis or a congenital scoliosis, that is something that has potentially a more variable rate. So that is the rundown, sort of the basics, the quick introduction of what is scoliosis.
Excellent, Keith. Thank you so much for providing that excellent overview. We'll wait for some questions to pop into the Q&A. I just want to kick it off. Keith, as you know, many of our patients will have parents who've had scoliosis. And, you know, if we have a mother who's having children, I mean, how do you advise them? When should they get checkups and how often? And let's say, you know, you've got a mom who's had scoliosis that needed surgery. How do we handle that?
It is a familial trait. It's not a direct gene, so it's not going to be inherited at the rate of half of your children or 25% of your children, but certainly the incidence or the rate of it is going to increase if you are a mother who is having children with scoliosis. Important to then ensure that they're having screening, so annual screening with that forward bend test, looking with a scoliometer, and then having the ability to then be checked or screened from an X-ray standpoint, balancing the risks of the radiation from X-ray to get a sense there. But certainly we do see that is more common if a mother has scoliosis, that her children will have scoliosis.
Great. We'll do one more question. I see one popped in. Why don't we do why is it more common in girls, Keith?
If you have an answer to that, I'd love to hear it. It's actually the rate of diagnosis is the same between boys and girls, but the more severe curves is what ends up being more common in girls. And I don't know that I have an answer for that. I'm not sure that we as a group of people who take care of patients with scoliosis have that figured out yet. So
great. Well, that's a great talk. In the best interest of time, we're going to keep it moving. I do see another question on anterior scoliosis correction. I'd like to save that one after Dr. Dahl's talk on DVT. Next up, we have nighttime bracing with Dr. Castelein.
Thank you, Dr. Samdani. I'll try to share my screen with you. And maybe you can give me a thumbs up if you see what I'm trying to show and if you can hear what I'm trying to say. Is it okay? Can you hear it? Okay, good. So my name is René Castelein. I practice in the Netherlands, and I'm very happy to be part of this faculty for this very interesting, very important meeting. And my topic is on nighttime bracing in idiopathic scoliosis. I have some disclosures right here, but let's get down to the real topic. And the first question I would like to pose is, if we're talking about treatment, the first question should be, what happens if you do not treat? And there's not so much literature on that, but the most important studies come from the group of Iowa, Laurie Dolan and Stuart Weinstein, who has really followed a large population, large cohort of patients that never had any treatment. And that cohort started in the middle of the 20th century approximately, and from the 1970s on, they have collected their data prospectively. So that's really a large database, one of the few in the world really where you can see over many, many years what happens to a person who has not been treated for scoliosis. And the good news is that with scoliosis, you can live just about as long as someone without a scoliosis. And based on these papers that were published, there's basically only 6 or 7 of them actually published, but everyone refers to them. So there's not too much material around. But if you look at these papers, you can see that these people are able to lead a very fulfilling life. They can have their profession, they can have a family life. It's very much similar to what other people might have and what people's ambitions may be. The only thing is that this is, of course, a historic cohort, and it's not clear yet if people in this day and age, you know, that have the same kind of scoliosis would deal with it in the same manner that someone in the 1970s of the previous century would. And also the area where this was done in the Midwest of America, rural area, is a little bit different from what people may encounter in more of an urban situation. So it's important to know what happens to these untreated curves. And we often suggest that scoliosis may not progress after you have matured, after you have become an adult. But in this series, 68% of the patients progressed after they had become mature. And only the curves less than 30 degrees at maturity tended not to progress. Even some of those may have progressed a little bit, but not too much. And then if you have a curve that goes over 50 degrees and keeps progressing, you can encounter some pulmonary issues. Of course, you have a lot of extra capacity in your lungs, so you may not notice it too much, but it may affect some of the pulmonary function. And then back pain is something that occurs to a lot of people in the general population anyway, but people with scoliosis, although you cannot say that the scoliosis causes the back pain, they may encounter a little bit more back pain than people without the scoliosis. And also these patients that are now in their 60s, 70s, although they have functioned very well, basically, they may state that they were a bit dissatisfied with their physical appearance. And many expressed that they wished modern day treatment had been available. So they were not so happy that they were never treated. Now, in this treatment, I've become more and more convinced that in conservative treatment, non-surgical treatment, there's still a lot to be gained. And this is one of the very important studies that's often quoted from the same group that I just mentioned. And it shows, it basically proves that brace treatment, if you're treated in a brace for your scoliosis, it leads to better results than if you're not treated. So if you look at this bottom line, it shows that 42% of the patients that were not treated had a relatively good result. At least they did not need an operation. And 75% of the ones that were in a brace did not need an operation. So 58% needed an operation if you're not treated in a brace. 25%, which is significantly less, need an operation if you're treated in a brace. But it's important to note that what we call, or what is called a good result in this study, is a curve that's not more than 50 degrees. And you may wonder if having a curve of 50 degrees or less than 50 degrees, maybe 48 or 47 degrees at the end of your growth period should be called a good result. I think many people would still argue that that is still a significant curve, of course. Now, the other thing that the study showed is that the more you wear your brace, the better the results normally are. So if you don't wear your brace, or you wear it from 0 hours a day to 6 hours a day, your results will be more or less the same as the people that did not have any treatment at all. And then when you wear it more hours, this is where the hours increase. If you wear it more hours, the good results start to increase also. So it's often said that you should wear a full-time brace somewhere between 18 or maybe 21 hours a day. But what this slide also shows is that after 13 hours a day, it becomes relatively similar to even more hours than that. But the number of hours you wear the brace and the way the brace corrects your curve is definitely a very important factor, of course. Now, what needs to be corrected in scoliosis? And many people say that it's the bony growth of your vertebrae. These are the vertebrae that needs to be realigned and needs to be adjusted so that their bones can grow very much more symmetrically than if they're not corrected. But I would argue that the most important structure that gets deformed in scoliosis is much more the intervertebral disc, this light blue thing here, than the bone itself. So these discs are very flexible, and once you develop a scoliosis, they can become very wedge-shaped instead of being parallel as they should be. They become wedge-shaped, and in my mind, this wedge shape of the disc is what makes your scoliosis into something structural that is more difficult to correct. Now, we're doing a number of studies on this issue where you can see this image from a very old book, 1904, this was written, where also that disc asymmetry is shown. And this is from our own studies with the MRI, where you can see that the center of the disc is displaced to the side, and when you correct the scoliosis, it comes back a little bit. And this is also a slide that shows that that disc becomes so wedge-shaped. So we're doing a number of studies looking at that, and I hope in the not too far future we'll be able to tell you a lot more about that. Now, we do know that scoliosis can be cured, and I'm not talking about the most common form that we're probably talking about right now, which is the adolescent form in your puberty. But if you have a very early case of scoliosis, when you're maybe 2-3 years old, we know, and this has been demonstrated by another Dr. Mehta, not the one that's talking today, but it was shown that you can really, by applying a plaster under anesthesia and doing a very good correction, you can cure the scoliosis. And these are some of my own slides where you have a scoliosis and you correct it in that plaster, you get a straight spine. And if you follow that after you remove the plaster, the spine remains pretty stable. Of course, we still don't know what will happen during your puberty. It might get worse again, so we have to follow that very carefully. Now, has the bone normalized in these patients? No, it's the disc. And if you look at these discs, the one here is wedge-shaped, and it's in the more corrected position, it's much more symmetrical. So I call conservative scoliosis treatment regenerative medicine of the disc. Now, we know there's many different brace types, and it's difficult to choose, and there's really not much in the literature to say that one brace is a lot better than the other. But my question would be, what about nighttime bracing? And I got interested in nighttime bracing because our Danish colleagues and also other people in Scandinavia are very happy with the results they obtained with the nighttime bracing. And we did a study where we looked at the full-time braces versus the nighttime braces versus soft braces. So these are the regular, the Boston brace, and also the Provident nighttime brace. But there's also soft braces around, and the soft braces just don't do so well, 62% good result. But the rigid nighttime braces get around 80% good results in this comparative study that compared a number of different papers in the literature. And the full-time braces did similar, I would say, but certainly not better than the nighttime brace. And there's quite a few studies around, quite a few published papers that show the effectiveness of the nighttime braces. And this is one that I found recently, only published in 2022, where the curves were treated, or the scoliosis, the patients were treated in full-time or nighttime braces. And it showed that the initial curve was very much the same between the two groups. The correction in the nighttime brace was a lot better, and the end result was pretty much the same, at least certainly not worse in the nighttime group than in the full-time group. The other thing it showed was that maybe the nighttime brace is worn a bit better. I don't think you can say that for sure because they didn't have any sensors in the brace. But based on the history of the patient, the conclusion was that the nighttime brace was worn better. So I think there's at least two explanations for the success of the nighttime brace. One is that there's a better correction. This is a patient of mine that was treated in a full-time brace, and this was the correction obtained in the full-time brace. And we changed it to a nighttime brace, and the correction in the nighttime brace was a lot better. And the other explanation could be that, and we're studying that at the moment also, is that during the night, your activity of different sorts of hormones, your growth hormone and other substances that make you grow, but also make your tissue regenerate. The activity of those substances is different during the night and during the day. So my conclusions would be that in scoliosis, the target tissue is the disc. Deformity of the disc should not become fixed, because then you have a structural scoliosis that's more difficult to correct. Early and effective treatment is needed, and nighttime bracing, in my mind, seems a viable option. Thank you very much.
Great. Thank you, Dr. Castelein. I see some questions in the chat. We are running a little bit behind on time, and we want to make sure that we get some of these wonderful patients that are going to share their story. And so I think what we'll do from here, Dr. Samdani and I will work to answer some of these questions in the chat, and then we'll save some of them if we end up with a little bit of time in the later segments, but we'll try to answer a lot of those in the chat. And we really want to start getting to our first patient story. So I'd like to introduce Ava to you all, and she will share her story with you.
So hi, my name is Ava, and this is my scoliosis journey. So when I was 14 years old, I went to my annual pediatrics appointment, and I was diagnosed with scoliosis. We were all very surprised and taken back because I had no obvious signs of scoliosis, but I had a pretty severe curve. I had 36 degrees. And why and how did this happen? Well, we don't know, but my parents went into research mode and we met with our pediatrics doctors. We were referred to surgeons, and they suggested that we have a brace and maybe if it got worse, had surgery, but my parents didn't want that. So after a lot more research, we decided to seek help from a clinic that focused on non-surgical options to reduce my scoliosis curve. So I went to an intensive boot camp. It was a 2-week intensive. I learned lots of exercises. I learned about core, and I learned about specific ways to stretch my legs that would help my spine. And I had a brace that was made specifically tailored to me. And all the equipment was customized just for my curve. There was lots of pain and discomfort from the intensive in the program. And I had a lot of fear of the unknown. I had no clue where this was going to take me. I didn't see the end of the tunnel. And I was scared to go back to school. I thought that my friends would see me as that girl with the back brace. But in the end, nobody really cared. And if they did, it wasn't that big of a deal. They would just ask a question, being like, hey, what is that? And I tell them, oh, it's my scoliosis brace. And if they asked any more questions that were negative, they weren't worth my time. So after that, I always thought to myself, was it worth it? Well, I wore my brace for 21 to 23 hours a day. And let me tell you, that did not just happen overnight. It took lots and lots of effort. It maybe took 3 to 4 months for me to actually be able to wear my brace for that long. And it was a really slow process. And on top of that, I also had a really rigid exercise program. I would do all my physical therapy, 1.5 hours a day. And that was a lot for me, especially as a 14-year-old girl. But it paid off because my curve is currently at 17 degrees out of brace. And not only was it reduced, but I avoided surgery. Doctors said that if I did nothing with my scoliosis, there could have been a chance that it could have gotten more severe. So was it worth it? I say absolutely. This is my curve in October of 2019. This is the very first x-ray when they first found it. And this is my curve 12 hours out of brace in February. It's holding. And I think that's great. So how am I today? I'm wearing my brace only 10 hours a day. And I really only have to do that for 9 to 12 more months. I no longer have to wear my brace to school. And I will always be exercising. I go to the gym, I run, I do core, and I plan to do that for my whole life. Not only is it going to be good for my back, it's just going to be good in general. I also continue to not have any scoliosis related pain, and I hope that will stay the same for the rest of my life. I live a normal and active life. So just letting you know, you're not alone. During my scoliosis journey, I felt alone. I was scared. I created a YouTube channel to help other teens with scoliosis to know that they're not alone. I'm just one teen with scoliosis looking out for you. So I created this YouTube channel based off with association with the Girl Scout project, my Gold Award project. It's called Embrace the Brace with Ava. I have lots of content on there. And if you want to reach out to me, you can reach out to me at embracethebracewithava@gmail.com or my Facebook page. And I would love it if you guys check it out. So thank you so much for letting me present today.
Ava, that's a really excellent presentation, and really appreciate you putting all this time and effort into helping kids that may have scoliosis, because as you know, the journey can be really scary, and sometimes you can feel alone. But this is one of the main reasons why we're doing this, is to make sure that others know that there's a big support group out there. What, just for my own understanding, what would you say was the hardest part of the brace? Was it feeling uncomfortable in it? Did it take some time to get used to it? Did you have to go back and maybe get it changed up a little bit?
So there was a little bit of like fear that if it doesn't work out, I'm gonna have to go back to the doctor and fix it. But I was always told that if it's uncomfortable, I'm not gonna be able to wear it. So that was not that big of a deal, because I knew it had to be perfect or else I wouldn't be able to wear it. But I honestly think the biggest problem out of everything was just the mental toll, that I was scared it was going to make me different from everybody else in a negative way. But if that's the biggest thing, wearing the brace is not that big of a deal. It's honestly, yeah.
Great. No, we really appreciate you making time and sharing your story, and then making those great YouTube channels as well. Next up, next up, we'll have Dr. Benny Dahl, who's going to talk to us about vertebral body tethering. Go ahead, Ben.
Thank you. Thank you very much. I hope you can hear me. My name is Benny Dahl, and I'm from Copenhagen, Denmark, and I'm going to talk about vertebral body tethering. So these are my disclosures. And first of all, I want to thank you for the invitation. I'm very honored to be part of such an esteemed faculty. But more than that, I'm very proud to be doing this with two patients. I haven't done this before, so I'm very impressed that we have two representatives of the scoliosis population. So thank you for joining us. So first of all, I want to say that modern scoliosis treatment is in Denmark a very centralized treatment. We have a whole team of surgeons doing so-called complex spine surgery, where we have centralized the treatment of pediatric patients and adult patients with what we call complex spine conditions. And as you can see, it's a big team. It's a big team of surgeons, and not only surgeons, but also other staff members who are dedicated to spine treatment. We have international fellows, and we also have an active research unit, which I think is a characteristic part of a modern complex spine team. So the way I look at spine surgery, I usually look at a timeline and the history of spine surgery that has gone through different phases over a little more than 100 years. And we have had implants, which means a lot also to scoliosis surgery, whereby we were able to correct the curvature of the spine. But more recently, within the last 5 to 10 years, the so-called vertebral body tethering has become increasingly popular and may find its place in the treatment of adolescent idiopathic scoliosis, or even idiopathic scoliosis in younger patients, younger than 10 years of age. So this would be a traditional patient in Denmark with adolescent idiopathic scoliosis. As you can see, there's this curvature of the spine up here. When the patient bends forward, you can see that there's a prominence of the rib. And the traditional or conventional treatment would be an exposure of the spine, where we open up the skin and expose the spine and put in screws and rods, whereby we can correct the spine and obtain a so-called bony fusion, whereby the spine becomes stiff in this part, this segment of the spine. And this means that the typical X-ray will look like this from behind prior to surgery and look like this after surgery. So this is still the mainstay of adolescent idiopathic scoliosis surgery. And we have pretty good results with a relatively low amount of complications and a good, what we call, functional outcome. So the difference between what I would call the conventional treatment and vertebral body tethering, as you can see here, is that with the tethering technique, instead of going in on the back of the spine, you approach the spine from the side. and you put in a tether, a flexible cord, whereby you put traction on one side of the spine. And I've taken these illustrations from Boston Children's webpage, which I can highly recommend. This is another illustration of the tethering technique. On your left, you have the traditional fusion, where you have the screws that are put in on the spine from behind, actually on each side of the spine, and a stiff rod is placed here. Whereas in the tethering technique, you put in the screws on just one side of the spine, and you put in this flexible cord that you tighten, whereby you correct the spine and you prevent the growth on one side of the spine, whereby the growth of the patient will correct the spine. And when you look at the spine from the front, it looks like this. You put in the screws on the side of the spine here, and you put in a tether, a flexible cord, and then you pull the cord, whereby you have a correction of the spine. And this is what it looks like. This is a publication where you can see that the spine has this curvature before surgery. And then the growth of the spine, the growth is prevented on this side of the spine, but the growth on the other side of the spine is what actually will correct the scoliosis. So as I just show you this illustration to show you that the incision very often in these procedures with tethering is smaller than in the conventional treatment. You go in on the side of the spine. You can do it with very small incisions and do it video assisted. This is an example of a screw. You can see the screw here, which is inserted into the side of the vertebral body. And then you have the tether here, which is flexible, whereby you have this, you can apply the traction. And I took this these images from a journal showing that you see this is the curvature of the spine. And here you see after surgery that the screws have been put in on the side of the spine. And this is 3 months follow-up, and this is 1 year follow-up. And you can see here from the side where the screws are put in on the side of the spine. That would be a typical, a good result after surgical treatment with the VBT technique. So the essential part here is, I want to stress that vertebral body tethering is not a miracle treatment of scoliosis. It's probably something we can use for a selected group of patients with scoliosis who have some growth left. And that's probably the key question: how much growth is left of the patient and thereby the spine? And we can assess that in different ways. Of course, the age, as the patient had her first period, all these other aspects. But bone age is an essential part, how much growth is left, because that will kind of guide us to how much correction can we expect, or will we get too much correction, which also can be a problem with the tethering technique. And even though it may sound simple to calculate the remaining growth, it's actually a pretty complex task. This is one technique we can use whereby we do X-ray of the hand. And you can see this is a very young patient where there is an opening of what we call the growth zones here, where these zones are closed here, indicating that the patient doesn't have a lot of growth left, and therefore may not be a candidate for vertebral body tethering. So I was asked, is there a difference in the outcome of treatment in the North America and the European countries regarding vertebral body tethering? I don't think there's any evidence to say that there's a difference in the outcome. Maybe on the European side, we've been a little more conservative, but these are some of the take-home messages I think are important. There may be a better mobility of the spine using the VBT technique. Maybe we'll have a smaller incision or exposure of the spine. However, it's very important to stress that we still see a relatively high number of patients who will need to undergo additional surgery after they have had the VBT operation, either because they have overcorrection or the tether breaks. That's something you have to take into account. We don't know how to calculate exactly the amount of growth left, and we still need some long-term studies. Luckily, as this forum indicates, we have some very, very high-profile international societies. Setting Scoliosis Straight is one, but the Scoliosis Research Society is another society, ensuring that spine surgeons from all over the world will meet on a regular basis and discuss these things. And I think that's an important thing. In Denmark, the treatment of scoliosis is centralized basically to two institutions. One is at the hospital where I'm located. In the US, the tether treatment is done under an FDA approval. So it's still very much controlled in the pediatric population. And I think that will ensure that we'll get some of these answers in the future. But to sum it up, vertebral body tethering is not a miracle treatment, but it may find a place in a selected group of patients where the growth of the spine can be calculated, and we can use the growth of the spine to make the correction of the scoliosis. Thank you very much.
Benny, great talk. Like always, there's a good question that came through. There's several that we were trying to answer, and I'm going to hand it over to Keith. Keith, you're moderating this one.
I am, but I do think that either Dr. Dahl or yourself, the question that we had early on in the webinar about the anterior spine correction that has turned into hypokyphosis without pain, trying to figure out if she needs fusion. So certainly Dr. Dahl, Dr. Samdani, thoughts on that?
So that tell me that question again, Keith.
Essentially, there's hypokyphosis after anterior spinal correction without pain. There's not much information about whether it says that the anterior spinal correction.
Okay, I got it here.
Failed. I don't know if that means that the curve remained large or was not able to fully kyphose, but.
No, I still think that's a valid question. I think we still have limited experience with VBT compared to other centers, but I still think that one challenge is that to get the so-called derotation of the spine. I think it's important to stress that scoliosis is a three-dimensional curvature, which can be a little challenging to correct if you just put screws in from the side of the spine, and that could cause the hypokyphosis, which in itself, if it doesn't, I wouldn't do a fusion just because there's a radiographic hypokyphosis. If the coronal correction is still okay, that would be my answer to that question.
And I would agree 100%, in our experience, the same thing, exactly.
We have a couple other questions. I'm going to try to combine two of them into one answer, and then we need to move on. But there's a question, Dr. Dahl, is the tethering method permanent like the fusion? And then there's also a question about whether the tether is removed once correction is achieved. We can likely, bring those two together, I think, and then we'll move to the next.
Yeah, it's permanent. For now, it's permanent, but we still see 10% of cases where the tether will break. And you have to do revision, but in principle, it's permanent. It's supposed to stay in there.
Yes, there are risks of having a repeat surgery to take the tether out, and once you're done growing, any growth modulation has been completed, and the tether will not be doing anything at that point. So we're going to move on. We're really excited for our next speaker. Happy to introduce Dr. Mehta, who is going to focus on returning to sports following spine fusion and non-fusion. Thank you.
Right. So thank you for this opportunity of talking to you about a very important aspect of surgery, which is return to activities after spinal deformity surgery. Now, I'm just going to try and get, can you see the screen completely, or is it, is the other, yeah? Okay. So these are my disclosures, not relevant to this talk. After an operation, usually we recommend that there shouldn't be any bending, lifting, twisting. Think of the sandwich, no BLT. You can have the sandwich, but no bending, lifting, twisting. But that is only for the short duration of time that's immediately after the operation. Soon after, we start looking at returning to activities. And here we look at two groups of activities. We look at school, college, social, recreational, going out outdoors, the routine stuff, but also we look at activities that involve non-contact sports, twisting sports, and so forth. And that's really important to get people back to. And there's very little in literature in terms of guidelines, but it's really important to identify who are the ones that can go back and If they don't, why they don't. The American Academy of Orthopedic Surgeons states that we can minimize activity for 6 to 12 weeks. It's something that is, again, it's not cast in stone. It's got to be sense checked with every single patient. But what's important is what I've seen in my practice is a good number of patients we can allow bending in the first few months, and a larger number of patients will get back to most of the activities in about 6 months. As you can see in this table, a lot of the patients really can get back to their activities in the first 3 months. As you can see, 66 patients going back to school, 28 going back to gym. Most of the patients can, carry a backpack and so forth. And if you extend that to 6 months, the numbers are even better. But there are some patients that don't really go back to their normal activities in this time, and some need even more time. So if you look at the factors that affect delay in return to school and gym, we look at things like, patients, children with high BMI, the slightly older child, the patients with larger curves, and the ones with longer fusions and lower fusion levels. But if we were to look at sporting in the context of non-contact, twisting and contact to collision sports, we can kind of create this kind of a grid and try and understand what are the specific activities that we can allow and what are the ones that we should try and avoid. Generally speaking, we find that with the passage of time, the enthusiasm or the conflicting interests in life allow that the physical activities in adolescents, young adults reduce, whether they are vigorous, moderate, males, females, and this is generally what we find. However, more importantly, in the context of spinal surgery, a large number of patients that want to go back can go back, and they are usually better than they were preoperatively. And these are typically younger patients and ones with the smaller curves. What we do find, however, is that the ones that don't get back is because they are either very stiff, the muscles are deconditioned, or sometimes more importantly, their parents or their pediatrician or their surgeons are discouraging them from doing so. So if you look at surgeon preference, there's a lot of variability in what we allow and what we prevent patients from doing. A lot of the patients will not be allowed to go back to certain activities. And there are lots of activities that we can let people go back to. So for example, in 3 or 4 months' time, we can get back to running, non-contact or even some contact sports, and in about 12 months, collision sports. But the snag is 20% of the surgeons, according to one survey, do not allow their patients to go back to collision sports ever. And more importantly, the more longer the fusion, the more lower the fusion, the less likely the surgeon is to allow them to get back to collision sports. Now, in this context, it's important to look at what this lower instrumented vertebra is. Now, these are 3 examples. The first one shows us a fusion to L4, the second one to L1, and a third one is an anterior fusion, which is up at T10. And viewing this in perspective, the shorter the fusion, the lower the shorter the fusion, the higher is the lowest instrumented vertebra, the more you have flexibility in your spine, and the better chance that you can get back to a lot of the activities. Now, in view of looking at this particular paper, return to athletic activities after posterior spinal fusion, the lower the fusion, we found that the patients and the surgeons are less likely to want to get back to their normal function. But this is, again, not set in stone and is very variable. When we looked at anterior versus posterior fusion, because we do a lot of anterior fusion in our unit, we did find that eventually by about the 1-year mark, most patients can get back to their contact and non-contact sports, whereas with the collision sports, 80% can. So again, that's true for both posterior as well as anterior fusion. With regards VBT, Benny has very well showed us what VBT can and can't achieve, but what's more important is that it can achieve a lot more. But what's important to realize is that the patients that have VBT were probably more active preoperatively, but that's again a very variable target. There are times that things go wrong, and there was one particular case reported in literature where a snowboarder had a neurologic problem when he got back to snowboarding 2 weeks after the operation. I don't think he asked the surgeon, he probably just did that, and that's not something that was recommendable. But equally, there are some patients that can have problems post-op, And it's something that we've got to individualize and see and make sure that things go right. What's really important in summary is that a majority of the patients will get back to their full-time education by about 12 weeks at maximum, and unrestricted physical activities in 52 weeks. Again, caveated by the fact that the persons with larger curves are less likely to get back in this time frame. Looking at the larger scheme of things with what we can and can't do, this survey showed that nearly half got back in 3 months to their usual activities, 63% back to contact sports, and 38% back to collision sports. In my practice, what our guidelines in Birmingham is, by 6 weeks, we allow patients to get back to school, college. I would get them to the gym as well as the pool, but with caveats that they shouldn't be doing deadlifts, and in the pool, try and avoid flips and try and avoid playing water polo and butterfly and so forth. But air travel, we can allow over 6 hours. By about 3 months, they can get back to non-contact, non-twisting sports. By 6 months, contact twisting sports, including dance and gymnastics. By 12 months, most activities. Again, caveated by the individual person and their specific requirement. This is one extreme example that I'd like to highlight. She's one of our Scoliosis Research Society brand ambassadors who had a spinal operation when she was a teen, a short segment anterior fusion. And as you can see from her history of golfing, she's been a #1 ladies PGA on a number of occasions and has a very, very extensive career of winning golf tournaments over the years. So what I would say is, based on what we have seen and what we would recommend, sky is the limit and the sky is blue. Thank you. And on that note, I'd like to introduce my next patient for a specific reason. And that is that we have a young 14-year-old who presented to us initially with a 90-degree curve. And with all the complexities of the COVID, etc., the curve unfortunately progressed to 120 by the time we got around to doing what we wanted to do, which was to do an anterior release, thoracotomy on the right side, 4 levels, T3 to L3 with 3 apical pontes. We thought we had done a reasonably good job, and I think we had, but the long and short is that we had a couple of roadblocks that kind of came up thereafter. On the first day, we had a drop foot, despite having a normal spinal cord monitoring, normal neurological examination after the operation. And Aisha, who's here with us, he's going to tell you more about it. We, as always, performed a full spine CT and MR on the very next day. We did nerve conduction studies that pointed to a possible common peroneal nerve lesion at the knee, perhaps positional, perhaps just the way it was. But fortunately for us, that recovered. That recovered in a few days' time. However, as a part of our CT and MRI, we hit upon another roadblock, which was that one of the screws, which was the right T7 screw on the opposite side to the foot drop, was incidentally found to be right next to the right inferior pulmonary vein. Now, we spoke to the cardiac guys and they were quite happy, and they said that, look, that screw is never going to get anywhere close to the vein. It's never going to be a problem. Don't worry, get back to what you want to do. You'll be fine. But we were a bit overcautious because we'd like our patients to get sorted at the earliest and get them back to the level that we'd like to. So what we did is we removed that screw, and we didn't lose any correction, as you see here, which was good, because now, hand on heart, we can sleep comfortably and we can let Aisha get back to all her routine activities. Obviously, this slowed things down a bit, but not to the point that Aisha is ever going to have any restrictions. So over to Aisha.
Hi. Hi, my name's Aisha. I'm 14 from the UK, and this is my scoliosis story. So I found out there was something wrong with my back in December 2020, and I got diagnosed with scoliosis in April 2021. I found out I had a 90-degree curve and needed urgent spinal fusion surgery in October 2021. It was a distressing, confusing, and scary time in my life. In December 2021, I was given a back brace to try and stop my curve from getting worse. I was told that it wouldn't make my curve better, but just keep it at 90 degrees. After 8 long months, I finally got another appointment to check my curve. In August 2022, I found out that my curve had progressed from 90 degrees to 120 degrees. This meant that I would need anterior posterior surgery, which is where they make an incision from the front side of my body, remove a rib, deflate my lung in order to get the best possible correction. The effects of scoliosis for me was that it made me very insecure and impacted my confidence a lot. I felt like I had to wear baggy and thick clothes all the time to hide it, and this made the summertime very difficult. Even doing a warm-up for PE class at school was extremely painful, and I had difficulty getting comfortable, which meant I had to sit in strange positions. I got 5 surgery dates within 2 months. My anterior posterior surgery was scheduled as 2 separate operations, but one of my surgeons, along with Mr. Mehta, Mr. Saul, suggested the option to do both operations in one day. With each date, the pressure got more intense until my surgery finally happened on the 8th of November 2022. I spent 8 nights and 7 days in hospital. My surgery was 13 hours long and I didn't even have a proper room. I was in a section of a ward with babies, only separated by a thin curtain, and we were told my mom would sleep on a bed next to mine, but she had to sleep on a reclining chair. When I woke up, I realized I couldn't move my left foot. I thought it was paralyzed. They immediately put me in loads of tests and scans, and we found out I had a foot drop, which is when I had been lying in the nerves of my legs for too long, so I temporarily lost feeling in them for a few days. From one of the tests for my foot, we found out that a screw in my metal rods was dangerously close to an important vessel and needed to be removed. On the 2nd of December 2022, I had another operation to remove the dangerous screw in my rods. I can wholeheartedly say that this was the worst and most traumatizing experience of my entire life. But my post-surgery results were amazing. At first, I struggled with breathing as my lung was deflated and I had a rib removed, so having a stool in the shower was helpful. Basic activities like brushing my teeth were challenging, and for the first 6 weeks, I was in my worst mental state ever. However, at home, I stopped taking pain relief medication, and at just 1 month post-op, I was able to go to my friend's birthday party at an escape room with no pain. At 2 months post-op, I had my own birthday parties. I went to the cinema and had a facial at a spa with no pain. After 6 weeks, I was able to go back to school on phase return with little to no pain, and at 5 months post-op, I went hiking to Licky Hills with my family and experienced no pain, as well as started going to the gym once a week to build my strength back up. In the future, I am expected to return to violin and badminton soon. I'm getting braces in a few weeks, and during the summer break, I'm going to travel overseas. Pre-op, running was painful, but now I can run as much as I like pain-free, and in a few months, I'm going to a scissor concert in London. I would just like to say that I'm so grateful to Mr. Mehta and Mr. Saul for giving me almost a perfectly straight spine, although it was so severe, and for giving me back the confidence that I lost during scoliosis. I also want to thank Setting Scoliosis Straight for allowing me to share my story and give me a voice. Thank you.
Wow, truly inspirational. Really appreciate you sharing that with us. Aisha, you've gotten a beautiful result from a very challenging curvature. So kudos to your surgical team. And obviously you're the one that's gone through the most. I've got a quick question for you. I'm trying to think if anything else pops up in the chat. What about the pain? Would you say, when did you truly feel that pain was no longer an issue? I know those first couple of weeks, I'm sure, were very difficult, but if you can kind of remember when did you really start feeling like yourself?
Obviously the first week in hospital, worst time of my life. I think I was just completely out of it and so much pain. I would honestly never want to go back. I think I only started feeling like myself. It was actually quite soon. So I had another operation obviously on the 2nd of December. And I think after Christmas, like during Christmas time, I started slowly because I was starting to feel less pain. I was starting to slowly go back to the things that I was doing before and doing it painless, normally. And just small things like waking up every day, being able to reach for my toothbrush, being able to put the toothpaste on the toothbrush by myself. Just small things like that just made me feel better in myself and just made me feel good.
Well, I can tell you that very inspirational, both you and Ava. We're grateful that both of you shared your stories with us. Excellent. Harvey, shall we hop over? So as you can see, you know, very inspirational hour here that we've spent. The Setting Scoliosis Straight Foundation, really, truly one of our missions is to educate patients, parents, surgeons. If you are interested, you can certainly contribute to our foundation. We would be very grateful. Doesn't matter what the amount is. There's a lot of different ways you can support us. You can go to our website. You can scan the QR code, which is what, you know, my kids have shown me how to do that. So if you want, you can scan that, go to our website. Anything would be greatly appreciated. Next slide. Of course, we want to give a shout out to our industry partners. They're listed on the screen: Biedermann Motec, DePuy Synthes, Stryker NuVasive, Medtronic, Alphatec, ZimVie. In order to make care for our patients better, it truly is a collaborative relationship between regulatory bodies, surgeons, caregivers, industry partners, and of course, our patient partners as well. Next slide. You know, you already have a link to a great YouTube channel that Ava put out. We also work together to create educational content. There's, you know, videos that you can look at. And again, you can scan the code, go to our website. There's a link there. We have some really neat work that we're showing there, including the research, publication, patient stories, some frequently asked questions, and there's past recorded webinars, including this one, for if you want to share this with anybody. Next slide. We've got 4 more coming up, webinars in 2023. They're really internationally based. Please visit our website for more information. Slide. Once you click out of this webinar, you will go to a survey. We would really appreciate it if you take some time and fill that out, as we want to continue to make this better for everybody. And I know on behalf of Keith Bachmann and myself, we want to thank our incredible faculty. That was phenomenal. Of course, our patient ambassadors, Aisha and Ava, and then the leaders from the Setting Scoliosis Straight Foundation, Michelle Marks, Harvey Lee, Praveen Solomon, and the rest of that team as well. And of course, all of our participants. And with that, we can adjourn. Thank you very much.